Good morning. Thank you all for joining us today. Dr. Don Yealy, UPMC's Senior Medical Director and Chair of Emergency Medicine, will update you on what we've learned about COVID-19 in the past several months and how we can inform our actions going forward. Then Dr. David Nace, Senior Medical Officer of UPMC Senior Communities, will share results of testing in our long-term care facilities and UPMC's efforts to continue protecting our vulnerable elderly population. After Dr. Yealy and Dr. Nace give their remarks, we will take your questions. Dr. Yealy.
Thank you very much, Paul, and thank you all for attending today. Each day we learn more about COVID-19 illness and infection, and I'm pleased to reassure you that the news is good. Since the start of the pandemic, UPMC has discharged more than 500 people who were safely treated and fully recovered from COVID-19 infection and illness. That's 5 times as many people as are currently hospitalized across our system. All signs that we have available to us right now show that this virus is less prevalent today than it was weeks ago in all of the communities that we serve. Tomorrow, many counties in the areas that UPMC serves in Pennsylvania will enter the green phase of the governor's plan for reopening. This doesn't change anything for UPMC. Throughout the past several months, we have been ready, and we've been dedicated to provide any necessary and essential care to all patients in Western Pennsylvania, Central Pennsylvania, New York, Maryland, and in Ohio. This includes patients with COVID-19 illness and infection, and all of those who need health care from our world-class system of hospitals and our other care sites, and from our physicians, nurses, and other providers. As things return to normal in our communities, we'll continue to safely take care of all of your health care needs, and we will continue to watch closely to make sure that we know what's happening in our communities. At the height of public concern, UPMC was caring for about half the number of patients in our hospitals that we normally would be. We are now back to caring for nearly 100% of the inpatient volume at our pre-COVID levels. Recent reports from Northern Italy indicate that the SARS-CoV-2 virus, that is what causes COVID-19 illness and infection, may be changing, with some patterns suggesting that the potency has diminished. We've tested widely here, including using our own UPMC-derived test and other tests that perform very highly, seeking to understand what's happening in our communities before the virus arrived, after it arrived, and right now. And this helps inform us on what we need to do. Our goal is to give you the best care and to understand what the threat of the virus is. Anecdotally, what we've been seeing in recent positive cases, that is people who test positive for the virus, is that the total amount of the virus that the patient has is much less than in earlier stages of the pandemic. Also, the number of new COVID-19 ill patients that we've had to place on a ventilator, and that's a machine to help you breathe because of respiratory difficulties, has decreased since the last week of April. We see all of this as evidence that COVID-19 cases are less severe than when this first started. In total, we've performed nearly 30,000 virus tests throughout our system, and the positivity rate, that is the number of people who have a positive presence of virus, is below 4%. That means the vast majority of people, even people who we suspect might have the virus, actually do not have COVID-19 infection or illness. We've actually performed tests on 8,000 people who had no symptoms of infection who were coming in for scheduled care. Overall, only 21 of those 8,000 patients have come back positive for carrying the virus. That's about 0.26%. Another way to look at it is 1 in 400. Let's put that into perspective. Your risk of getting into a car accident if you go back and forth across the turnpike in Pennsylvania is greater than your risk of being positive for asymptomatic COVID-19 infection. This should give you some reassurance that the risk of catching COVID-19 from an asymptomatic person, that is someone who doesn't even know that they have the infection, in our communities is very small today. And I want to emphasize it's the communities that we serve. We will continue to assess our communities and we'll work hard to find any changes if they happen. We have always been prepared for the worst, but we respond to what we know is happening and what care needs to happen. There remain high-risk groups, either people who catch the virus easier or have more dangerous effects once they have the viral infection, especially in long-term care settings. Dr. David Nace will give you more insight into our efforts to guide UPMC-run and other long-term care skilled nursing facilities and how to protect our elderly across the state and across the nation.
Thank you, Dr. Yearley. Throughout the 30 UPMC senior communities that are home to over 3,000 older adults, we've not had a single case among our residents of COVID-19. But we know that this is a vulnerable population. And since the beginning, we've been trying to adapt our testing strategy based on evolving information and our expanding testing capacity. We do not want to wait passively for this virus to appear. And our philosophy is that we need to hunt it down. With the health and safety of our residents as a top priority, we've developed a plan to offer COVID-19 testing to asymptomatic residents at our UPMC Senior Communities facilities. This means that we're going to be offering the nasal swab test to residents who have no signs or symptoms of the virus. This asymptomatic screening practice is fully consistent with UPMC's other asymptomatic testing process, where we look at individuals going through essential hospital services. And our testing process is more assertive than the current public health guidance requires. This will allow us special insights that can help us aid an understanding of how the virus is spread in this population and will help to inform public health officials in our communities about the needs of senior care facilities. Right now, as a country, we do not have strong evidence to suggest that one testing strategy is better than another. We hope that our program will help to fill in some of the missing gaps in the current evidence. Starting last week, we offered testing to all residents of UPMC Canterbury Place in Lawrenceville as a pilot testing program. At that time, we tested 108 residents, and all 108, I am happy to say, were negative for the virus. Earlier this week, we tested residents at Heritage Place, and we tested 90 individuals there. All the results, again, were negative. We're now expanding this testing program throughout all our skilled nursing facilities, assisted living facilities, and personal care facilities that are part of UPMC's senior communities. And we'll be doing this over the coming weeks. In addition to testing our residents, though, we've developed a plan to also offer testing to our UPMC communities staff. And this testing would involve the antibody testing. And it has begun starting yesterday at Canterbury Place. This blood test will show if somebody has been exposed in the past and has evidence of a past infection with the virus. As a UPMC Senior Communities employee, I actually had this testing done yesterday and am currently awaiting the results for this. By providing antibody testing to our employees, we will gain valuable information on how exposed our healthcare workers have been to the virus up to this point. Because no residents or employees have tested positive at Canterbury Place, it is safe to say that if an employee is found to have a positive antibody test, the likelihood is that they obtained this outside of our facilities, in other words, in the community. We expect the results will provide reassurance that the prevalence of COVID-19 among healthcare workers carrying the virus is low. Our employees are safe because we wisely follow and execute the right practices and precautions. All antibody testing for UPMC Canterbury employees will be completed as of this week, and we will move on to our other locations. And we will share our results to help inform the public health authorities and policymakers nationwide. Beyond our testing program, we also want to highlight that we have been working with the legislature in which we helped draft a portion of House Bill 2510. This was passed by the House and Senate and signed by the governor late last week. This bill helps promote readiness and a collaborative response to long-term care facilities, where nearly 2/3 of the 5,742 deaths in this state attributable to COVID-19 have occurred among residents of long-term care facilities. In addition to helping long-term care providers prevent the spread of COVID-19 in their facilities, the legislation also creates 6 regional healthcare collaboratives. This legislation, spearheaded by House Speaker Michael Turzai and co-championed by Representatives Reedshaw and Courts here in Allegheny County, builds upon the educational support and clinical coaching programs. These programs are regional public-private partnerships between departments of human services and healthcare centers around the state to support long-term care facilities. UPMC leads the program for Southwestern Pennsylvania. This act will include 3 major components. One is enhanced testing and surveillance that will be available to facilities and will include on-site testing. Secondly, there will be enhanced infection control consultation capabilities and implementation, including contact tracing. And we will have advanced clinical care services available, including remote monitoring and physician consultation. In collaboration with Speaker Turzai and the General Assembly, we were able to pull this legislation together quickly and effectively. When there is a public health crisis, Pennsylvania policymakers have realized that they can always turn to UPMC experts for guidance. Protecting the elderly is a critical, important component of safely reopening society, and UPMC is sharing what we've learned so that long-term care facilities in our region and nationwide can replicate our success and hopefully prevent untimely deaths.
Thank you, Dr. Nace. I'm proud to work with you. All of this news is extraordinarily reassuring. UPMC planned and got ready, but our actions were always guided by the reality of what was happening, not only in our hospitals, but in our testing centers. COVID-19 never surged to levels in our communities that we weren't able to provide the highest level of care. And we've seen a continual decline in positive test results over the past weeks. At UPMC, we are back to treating the same number of patients as we were before COVID-19 entered our communities. And we are doing this in some of the cleanest hospitals and outpatient sites with the best infection prevention techniques you'll find anywhere. The rapid return of patients to our hospitals and all of our care sites reflects that there was pent-up demand for care, particularly from UPMC. Moreover, with this return of patients at UPMC in the past month, there were no cases of increased or positive COVID-19 illness in our patients or in our staff. This reinforces that our locations are safe and that we use techniques that protect everyone. It also reinforces that everything that's been done in our community has helped control the prevalence of COVID-19 and that the strength of that infection pool is diminishing. In another example of UPMC leading the region, we provided evidence-based guidelines called the UPMC Sports Playbook, and this is to keep everyone safe as we begin activities. It contains recommendations from a multidisciplinary team of clinicians and researchers to assist coaches and athletic trainers in creating a safe environment for resuming organized sports. We will continue to protect vulnerable patients and provide guidance on how to duplicate the successes that UPMC has had in our senior communities and help prevent nursing home outbreaks. And we'll keep learning and working towards COVID-19 treatments and vaccines. That's what you expect, and it's what we do at a top-tier academic medical center. What should you do now? I hope you feel confident in getting back to your life, using the simple and impactful measures that we've talked about before while restoring daily activities. Together, we controlled the virus in our communities, and it's time to move to a new, restored approach to human interaction and safely reopen businesses. Please enjoy your summer. My UPMC partners and I will keep a close watch on the virus, and we will be ready to care for you no matter what needs you have, now and in the future, for any type of illness or need. Thank you.
Well, thank you, Dr. Yealy, Dr. Nace. And with that, we will now take questions from the media. All who all of whom are joining us remotely online. To ask a question, you'll have to go to the participants icon at the bottom of the page and press the Raise Your Hand button. That will put you in the queue. I will read your name and your line will be unmuted for you to ask your question. Make sure that you unmute your line at your end likewise. We will try to call on as many different media outlets as we can in the time that we have allotted. We also have a number of email questions, and let me go to one of those first. And Dr. Nace, will the senior communities be opening up to allow more family visitors?
So this is a question that I think is on our minds, whether we're family members, whether we're the residents of our long-term care facilities, or whether we're the providers taking care of patients. We're longing to start to get back to some sense of normal. What we have done is really put into place protections to really take care of a vulnerable population here. And those protections will continue to remain into effect at this point in time. We do know that as society opens up, there will be greater pressure to start opening things. We've already started looking at ways we can safely start to resume some of the normal activities, including in particular around our independent living facilities. But I think what is really important to understand is we have to take a measured, cautious approach here. And also, we have to understand that even as we move into the green phase of things, the guidance from the state and the guidance from other authorities is that we need to wait at least 28 days following that entry before we can start to loosen within our personal care, assisted living, and nursing facilities.
Thank you, Dr. Nace. First question comes from Paul Goff, Pittsburgh Business Times. Paul, go ahead, please. Paul?
Yes, hi. Thank you very much. Can you hear me okay?
Yes, sir. Go ahead, Paul.
Okay, thank you. Dr. Yealing, Dr. Nace, you talked about going to the green phase here in Allegheny County in southwestern PA. Two questions. One, what should people and businesses do, especially businesses in the interactive phase in this opening? What would you recommend that they especially look at, businesses, whether you're retail or an office or anything, to be ready for this and to have as few problems as possible? And then also, what do you expect that there will be more cases in your footprint as in the coming weeks due to going green?
So let me begin to answer those. I'll take them out of sequence. I can't predict whether or not there'll be more cases. And cases could mean more people who test positive or more people who are sick. And those are really two different things. Not everyone who acquires the virus actually has any symptoms or develops any illness. And so I don't know. It would not surprise me if there were more people who tested positive. I can't tell what that level of illness will be. What I can promise you is that we will watch very carefully as all types of interactions change, both in symptomatic patients and doing that screening in people who really have no findings of it. Like we did at the beginning of this pandemic, UPMC wants to know before it's already obvious what's happening in our communities. So I can't predict the future for you. Anything's possible, but we will stay on it. You asked about what should businesses do, and it's the same basic approach we've been talked about. Do the simple, smart things, and the governor has suggested this. First and foremost, if you're a business owner or someone going to engage in a business, don't go there if you're sick. At one point in time, we thought workers who came in every day, no matter what, were good workers. In fact, they can be the kind of people who unintendedly transmit infection, whether it's COVID-19 or anything else. Don't go to work or don't go out if you're feeling sick. Number two, if you're going to be in an enclosed area or in a crowd, wear the mask. Wear the mask right. If I can see your nose, you don't have it on correctly. Wash your hands frequently, no matter where you're at. Keep a little distance. And if you're a business owner, make sure that you've created flows and structures such that distance isn't a challenge to obtain and that barriers are there that don't impair with your business but keep people apart. Those simple things are way more important than fretting about, should I take a medicine, should I have a test? That will keep things manageable.
Thank you, Dr. Yealy. Next question, David Winter, from Penn Live and the Harrisburg Patriot News. David, please go ahead. David?
Can you hear me?
We can hear you. Go ahead, please.
Good. Thank you. I'd like to ask Dr. Yealy regarding those statements you made at the beginning of your remarks regarding the level of COVID-19 in your communities, and do you feel like that there's any unique characteristics of your region, your community, or do you think those things that you found in your community, that pretty much applies everywhere in the United States? And I'd also like to quickly ask regarding your absence of cases in your skilled nursing facilities, what do you attribute that to? And do you think it's pretty much an equal or an apples to apples type comparison compared to all those places that we've heard about that have had so many cases among long-term care residents? Thank you.
I'll leave the nursing home questions to Dr. Nace. You asked about are the observations that we have in our communities, whether it be central Pennsylvania, western Pennsylvania, New York, Maryland, is the change that we're seeing with perhaps less intensity, is it emblematic of anything? I do not think our observations are unique only to western Pennsylvania, central Pennsylvania, or the UPMC communities. I also don't think that means they're identical everywhere. As you've seen and heard, not only across the US, but across the globe, the virus has a different velocity and penetration in different locations. We're hearing of much more activity, for example, in the southern hemisphere right now. They're at a different point in time in their exposure to it. What I can say to you is what we're seeing, where people don't seem to have the same level of sickness as a few weeks ago, aren't requiring as much intensive care, is not peculiar to western Pennsylvania or central Pennsylvania, but it's also not ubiquitous. We actually probably are getting better at how we make decisions on providing care to patients too. So it's probably a complicated interplay between the virus, people, and healthcare provision that allows this observation to be true in our areas and in other areas.
And I'll answer the portion with regards to the skilled nursing facilities. I think with regards to what we've done, we've followed some of the very basics of infection control that other facilities have also considered and tried to implement as well. We have had a long experience in terms of certain things that with our experience around influenza management and prevention that kind of help prepare us for facing the issues around COVID. Basic infection control practices are important, but making sure that they're executed. I can put into place the policies and procedures, but again, our staff have to carry those out, and our staff have done a phenomenal job in carrying out these policies. But I think the things that we've learned from influenza that are important that may separate us a little bit is the attention to surveillance, and not just with the capability of testing. We can't test our way out of COVID. That's an important thing to consider. It's a tool, and like all tools, has to be used appropriately. With influenza, what we've done in the past is we've been able to do surveillance using clinical signs and symptoms and making sure that everybody in our facilities are paying attention to our residents and attending to those things that are typical symptoms as well as atypical symptoms. So I think that's a strength of our experience over the years of looking for this and just suspecting the case. I also think that our communication among our staff and among our facility leaders with our daily command center calls that we've had, making sure that we communicate on a recurring, regular basis and reiterating the same thing on a regular basis to make sure that people are still paying attention to it, re-educating in terms of the use appropriately of personal protective equipment. So, and then of course, I think also, we are fortunate here because we are associated with UPMC, and UPMC has the resources and the expertise nationally to be able to lead in this particular area.
Thank you, Doctor. Next question comes from Aaron Martin, WPXI TV. Aaron, go ahead, please.
Thank you for taking my question. This is actually for Dr. Yealy. You'd mentioned that you were seeing less of a total amount of the virus than earlier in the pandemic. I wanted to see if there was Any idea why these coronavirus cases seem to be less severe than they were just a month or two ago?
That's another excellent question, and the honest answer is I'm not completely sure yet, nor are any experts around the world. Viruses do change over time. You've heard the term mutation. That means part of the genetic code changes. Sometimes that can make a virus become more infectious and more harmful. Sometimes it can make it be less. Coronaviruses, like COVID-19, will change. It does not look like COVID-19 changes as much as many other viruses you're familiar with, like the flu, but it does change. Secondly, we know that viruses not only interact with people, but interact with the environment, and that includes the weather. And so there's often a seasonal component to it that may play into this, just like we noted that in the southern hemisphere, COVID-19 illness is beginning to ramp up. They're on a different schedule than us. Finally, we are probably better at making decisions and identifying who needs what specific type of care, even though there aren't any particular specific interventions right now to stop the infection cold in its tracks. I think everyone has gotten better at it from the provider side, and I think patients are actually much more in tune to what to watch for. So I think you put all those things together and you realize there's probably less exposure to the virus and maybe some subtle changes in the viruses that altogether right now make the pattern seem less. I can't tell you whether or not that will be maintained. What I can promise you is that we will watch closely and be ahead of any changes that happen, whether it be in the virus or in the people who come to us for care, or even those who don't know that they have the infection yet.
Okay, let's go to Natasha Lidstrom from the Tribune Review. Natasha, please. Natasha, are you still there?
I'm trying to unmute. Is it working now?
It's working now. Very good, Natasha. Go ahead.
Okay, great. You guys brought up how UPMC was among the first to really ramp up testing in general in hospitals in the region. Governor Wolf and Dr. Levine had called for testing of all nursing home staff and residents back on May 12th. Perhaps this is a kind of a logistics question in terms of how to roll it out in nursing homes, but can you explain why it took until now to get this started at Canterbury Place? And then secondly, I'm curious, why not give all residents the antibody test as well, like you guys did for the hospital patients? Is it a cost issue or about the speed or can you explain the approach there?
Sure. So, Natasha, great questions. And with regards to the requirements or the guidance around testing, there are no requirements in place with regards to testing specifically for nursing facility residents. There were recommendations that were put into place, and as the notices had said, that there are things that you should consider in terms of testing. When they were talking about testing all residents, they were talking about facilities that actually have COVID in them. They were talking about sampling a subset of individuals, potentially, considering that, for facilities that did not have that. What we've decided to do is to try to get a baseline look at what's going on in our facilities by actually doing the sampling right now to see if residents have that. And then what we're doing moving forward is also a procedure of sampling individuals for new admissions that are coming in. All new admissions are being screened at this point in time and tested. We're also looking at high-risk individuals who might come in and out of the facility on a regular basis for radiation oncology or chemotherapy or for dialysis. We've identified certain high-risk individuals that we have to pay a little bit of closer attention to. With regards to the employees, we're offering the antibody test because we want to see what's happened up to this point. We don't really have good information to tell us what was happening prior to the start of the recognition of this outbreak. Was this going on previously? And the employee testing will help us in terms of that. With regards to the use of the antibody testing for the residents, it is still recommended that when you do the testing, that it's done with the PCR because that tells you what's happening right now. For the residents, the only information that would provide us is what they were exposed to in the past. And that information doesn't really change our practice. And for that reason, we don't want to subject them to having a test that may not really help inform our practice moving forward.
Okay, thank you. Next question comes from Bill Kibler, the Altoona Mirror. Bill, please go ahead.
Thank you. Is both the potency and the contagiousness of the virus declining?
That's an excellent question. And I think what you're asking is it getting harder to pick up the virus? And if I get it, do the effects seem different? And they have a tendency to overlap, even though you might think of them as distinctly different. The amount of symptom you have and the course you have, as well as the ability to develop any symptoms at all, in part depends on how much of the virus you get, how much of a defense you have, and that varies amongst people, and then those potency issues. So in fact, they're kind of interdigitated and can't be separated, although each term has a distinctly different meaning. We think that the total amount of virus looks like it has come down. Even in people who we test positive, they seem to have less of it, which would mean that they would more likely than not, but it's not predictive in any one person, have fewer symptoms or recover better, and they're less likely to infect someone else. It's not that there's any formula that a certain amount of virus means you'll never get sick or never infect, but as a general term, those links exist.
Okay, next question comes from Paul Van Osdel at WTAE. Paul, please go ahead.
Good morning. I wonder if Dr. Yealy, you perhaps could give an update on the vaccine development. I know that's not in your direct purview, but I ask that because the New York Times is reporting that 5 companies have been named finalists by the Trump administration for development of a vaccine, and that's going to entitle them to a lot more money. And the Pitt UPMC group is not in there. So I just wanted to see if you could update the vaccine development.
That's a great question, Paul. So what are the status of the vaccines? So we've been in touch with the Food and Drug Administration and are working out the terms of the clinical trial for the patch vaccine that was in one of our earlier press conferences. That's really not only novel from a vaccine approach, but the delivery mechanism separate from COVID-19 is really an exciting new opportunity. Between Pitt and UPMC, there are 3 candidates for vaccines that are in various stages. The Center for Vaccine Research has 2 other candidates that are in preclinical partnerships with industry and trying to become ready so that they can begin that human testing. One is based on a measles vaccine that's been given to billions of children, and so it looks like a very useful platform, and it will be manufactured together with Merck. Merck is one of the industry giants that's been chosen by the White House to receive that special funding you talked about. The other vaccine worked on through Pitt and UPMC uses RNA that's injected. There is animal testing underway right now, and if that goes well, we actually have a partner available to begin manufacturing, so that's a little bit more preclinical. So the short answer is all 3 vaccines are working their way through, one of which has a link to one of those that you noted that the White House has chosen.
Okay, thank you. Next question, Sarah Bowden, WESA. Sarah, please go ahead.
Hi, good morning. Dr. Yealy, you talked about how perhaps the virus is mutating to become, I think you said, less deadly. I'm wondering though, you cited Italy in your comments, and I'm wondering if maybe like the virus just kind of burned through all the most vulnerable people. And so the people who are now getting infected are just less susceptible to adverse outcomes. And perhaps it isn't so much mutating in a way that we would hope that it's mutating, and more to the point that just the most vulnerable people were impacted earliest.
Well, I think that's an excellent question. I don't attribute the change solely or even predominantly to mutations. We simply don't know what that impact is, yes. And you are correct that over time, the population's susceptibility to the virus changes. And obviously early on, the most susceptible come in contact with the virus and get clinical infection. There's no doubt that that plus the weather plus other factors all play in together with changes that we see in Italy, in Western Pennsylvania, other places. I can't tell you which one participates the most fully, but I think you're on to the right type of thinking, which is that viral pandemics are complicated. They can wax and wane, and some of those features we control, some we don't control.
Okay, thank you, Dr. Yealy. Next question, Eric Sieverling from the Mon Valley Independent. Eric, please go ahead. Eric, are you there? Okay, while we're waiting for Eric to maybe get connected, we'll keep trying. I have an emailed question. Dr. Yealy, what can you describe about the effects that we've seen with patients postponing essential care, tests, screenings, and other medical care?
So unfortunately, we know directly about some of the negative consequences that COVID-19 fear to actually engage a healthcare provider, what it can create in patients. I know of people, I do emergency medicine when I'm practicing clinically, in whom their opportunity to avert a bad outcome from heart disease, stroke, other acute conditions has been impacted because previously they may have been afraid to either seek care or come in for care. We also know that the total number of cancer visits has not returned back to what we fully had hoped for. And in part, that's because people may put off scheduled examinations, screening examinations, and that may change their opportunity to have either a better outcome or a simpler care regimen by delaying the opportunity to identify whether it's cancer, underlying hypertension, diabetes, lots of different things. So there is a real risk to delaying health care. Sometimes it's very direct and very short term. Other times it's much more insidious. It's why we're trying to remind people. We know what the prevalence is in the community now. We'll continue to look at it, and we will provide you with safe platforms, telehealth or safe visits in our hospitals and our care sites. You don't have to worry about acquiring the virus when you come in for care. Don't let that fear be the thing that keeps you from doing the right thing.
Okay, thank you. We'll go to Maria Simbra at KDKA TV. Maria, please.
Good morning. Can you hear me?
Good morning, Maria. Go ahead.
Good morning. Fantastic. A couple questions for Dr. Nace, please. So you mentioned that all of your long-term care residents are getting PCR testing, which gives you an idea of what's happening right now. Will you be offering this testing also to the staff, and why or why not? And then also, what will the procedures be if you do have a positive test amongst a resident or the staff?
Sure. Thanks, Maria. Good questions. We are offering, as I said, the antibody test presently to our staff to give us an idea of what we've faced at baseline, what's been exposed up until this point. We are continuing to offer testing to our staff in terms of the PCR testing for individuals who are symptomatic or who we think may have been exposed, or if we find that there is a case within our facilities, doing the contact tracing and identifying other individuals, we would offer the PCR testing in those circumstances. So one of the challenges that we have in repetitive testing, and where this has become so difficult, I think, from a national standpoint, is there's no really agreed upon set of guidelines for how often to do the testing. The testing with PCR tells you what's happening right now, but in another day or so, that testing may not be reflective of what's going on. That's led a lot of people to think that you need to constantly test. Testing every 3 days, testing every 7 days, testing every 10 days. And the answer is we just don't know how often to do that. We do know if you have symptoms, if there's an exposure, if there's a concern, at that point in time, doing the PCR testing is what is most appropriate.
Okay, thank you. We have a few follow-up questions, which we'll try to get to. The first from Paul Van Osdol at WTAE. Paul, please go ahead.
Yes, thanks for taking this question. This is actually a separate question. There's a community group that's planning a news conference later on today, and one of their focuses is to oppose the state funds going to UPMC and other academic medical centers as part of this bill that's apparently not been approved yet by the legislature, but it's been proposed by Speaker Terzai. I know, Dr. Nace, you expressed your thoughts on this earlier, but I'm just, in general, if you could respond to the thoughts of some of these groups that UPMC is simply too big to be getting additional funding from the federal government.
Yeah, thanks, Paul. And I think there might be some confusion here. So House Bill 2510 was actually passed by the House. It was passed by the Senate, and it went to the governor and was signed. So there is that bill that has been signed, and this is a bill that is providing funding through the CARES Act and through other funds through the CDC and the federal government to provide relief to long-term care facilities in general. So the funds are designed, there's a component that goes through these, what are called the educational support and clinical coaching programs. These are public-private partnerships between the Department of Human Services and academic health centers around the state. Not just UPMC, but University of Pennsylvania, Temple University, Penn State, Geisinger, the Wright Center, and Allegheny Health Network. As a matter of fact, as part of this process, we've been actually collaborating with the Allegheny Health Network in this. Those funds, though, are directed towards the nursing facilities. Then right now what we need and what we've identified is a need to coordinate services to the long-term care facilities. What we have found through our work is that facilities are saying we need access to testing. We need assistance with education. We need assistance with staffing. And there's not a strong coordinated effort in terms of that. And this bill provides the funding for that. It also provides hundreds of millions of dollars directly to the personal care, assisted living, and nursing facilities in order to support their efforts as well. So this is not money that's going directly to academic health centers for the purposes of supplying the academic health centers. This is actually money that's meant to provide care. And just give an example. In this region, we've actually formed a joint regional COVID-19 council that meets on a regular basis, and we've been reviewing facilities, non-UPMC facilities, where we've identified COVID-19 outbreaks. And we've been able to put into place some early processes, including testing on site, that has allowed successful resolution of some of those outbreaks. It's helped to kind of solidify and protect the other residents within that facility. So this is a very effective model. I think it is a model for the rest of the country that needs to be put forward, and I know that it's going to make a difference.
Thank you, Dr. Nace. Next question comes from Mallory McElwain from the Williamsport Sun-Gazette. Mallory, please go ahead. Mallory, please unmute.
Hello, can you hear me?
There you go. Go ahead.
Hi.
Go ahead, Mallory.
So I was wondering, has UPMC been involved with the care situation at the Jersey Shore Manor Care, and is there any update on that?
So UPMC has participated in assisting that facility. I don't have the details on that because that is not within the Southwest region where I have access to non-UPMC facilities, and it's also not part of UPMC senior community. So unfortunately, I can't provide an update for you on in terms of that, but that's something that we can look into for you.
Okay, thank you. And our final question will be a follow-up from Sarah Bowden at WESA. Sarah, please go ahead.
Hi, clarification for Dr. Yealy. I believe earlier you said that UPMC had returned to its normal level of care, but then you also said that you haven't seen a return of cancer patients like you would like to, or as you would have hoped. And I'm just wondering if you could kind of clarify that for me.
Yeah, I think what I said is that we nearly had returned back. And one area where I think there still is the opportunity for restoration of that important and necessary care was within the cancer area. It's not that the cancer centers are at half of their volume as some might have feared. We are largely back, but not completely back. And so those statements can both be true at the same time.
Okay, thank you. And that concludes the time we have allotted. Thank you all for attending. In about 45 minutes, we will email media attendees a link to download high-definition footage of the entire press conference, which we encourage you to use in your news reports. Reporters who have follow-up questions are encouraged to contact our media relations department. And as always, please follow at UPMC News on Twitter for updates. Thank you very much. Have a great weekend.